Oral semaglutide reduces cardiovascular events in people with type 2 diabetes with atherosclerotic cardiovascular and/or chronic kidney disease. So semaglutide, as you know, is a long-acting GLP-1 receptor agonist whose once-weekly injectable form has indications for the treatment of people with obesity, type 2 diabetes to reduce blood sugar, but also to reduce cardiovascular risk. As we know, many patients and prescribers are resistant to taking prescribed injectable therapies. Many patients who have an indication for these therapies are not getting them, so the development of oral formulation was felt to be important. This is a novel delivery system with a tablet using a molecular entity called SNAC. SNAC neutralizes the local pH to stabilize semaglutide in the highly acidic environment in the stomach and to protect it from degradation by gastric enzymes. SNAC reduces semaglutide oligomerization, which could affect absorption. SNAC increases membrane permeability to enhance transcellular absorption of semaglutide. So the tablet sticks to the gastric mucosa, and only at the point of contact does it deliver the medication. This once-daily formulation is currently available for hyperglycemia and has been shown to have favorable effects on body weight and cardiovascular risk factors. The Pioneer 6 study demonstrated cardiovascular safety but not efficacy of oral semaglutide. So in the SOUL study, 9,650 patients were enrolled and started on low-dose semaglutide at 3 milligrams once daily versus placebo, titrated at 7 milligrams and 14 milligrams as tolerated. Mean follow-up was about 4 years. The product was used on top of standard of care for glycemic management and for cardiovascular management. Key inclusion criteria included patients with type 2 diabetes over the age of 50, an A1C between 6.5 and 10, and a history of either CHD, CVD, PAD, or CKD. Key exclusions are listed here. Here are the baseline characteristics. Average age was 66, 70% were men, average A1C was 8.0, and BMI was 31. These patients had relatively preserved kidney function with an eGFR of 74 on average. Median hsCRP was 2.0, and the use of SGLT2 inhibitors was over 25%. The primary outcome of cardiovascular death, MI, and stroke is shown here. You can see the oral semaglutide curves diverging within the first 6 months. The hazard ratio was 14% relative risk reduction with a p-value of 0.0028. This is a statistically significant, positive finding for this 3-point composite of cardiovascular death, non-fatal MI, and non-fatal stroke. There was an absolute difference of 2% over 3 years, yielding a number needed to treat of 50. The first hierarchical confirmatory secondary outcome of 5-point kidney disease events achieved a hazard ratio giving a 9% relative risk reduction, but the p-value was 0.0967. The confidence intervals crossed unity, missing statistical significance for superiority. So subsequent confirmatory outcomes in the hierarchy becomes exploratory. There was a 7% reduction in cardiovascular death, which was directionally favorable but not achieving nominal statistical significance. Major adverse limb events had a 29% relative risk reduction. Recall this is exploratory since the 5-point kidney events do not reach significance, therefore hypothesis generating. Secondary outcomes including the individual components of the 3-point MACE plus hospitalization for unstable angina, coronary revascularization, all-cause mortality, heart failure, etc. were all directionally consistent with the overall trial findings. Looking at subgroup analysis of age, sex, BMI, A1C, eGFR, geography, there was consistency of the treatment effects across all these subgroups. Specifically, with or without the background use of SGLT2 inhibitor, there was no differential treatment effect, suggesting that the treatment benefit of semaglutide is independent of the benefits from SGLT2 inhibitors. Mean A1C, mean body weight, and mean hsCRP were all significantly reduced with oral semaglutide versus placebo. Of note, the A1C and body weight reductions are consistent with previous clinical trial findings. So in conclusion, oral semaglutide was superior to placebo in reducing the incidence of 3-point MACE in people with type 2 diabetes and ASCVD and/or chronic kidney disease. There was consistent benefit of oral semaglutide across subgroups by age, sex, BMI, eGFR, and concomitant medications. The overall safety profile in the SOUL study was similar to that observed in previous clinical trials, and no new safety signals were found. Oral semaglutide is the first and only oral GLP-1 receptor agonist with proven cardiovascular benefits.